Good morning, everyone. Welcome to our first podcast presentation. Today, our speaker is none other than Dr. Nadia Baker. She's a specialist psychiatrist who completed her medical degree at the University of Pretoria, Turks, into 2012. That's 1 year shy than me. I think we were probably the same. I was in 2011 when I finished, followed by Masters in Medicine Psychiatrist in 2020. She's also a fellow of the College of Psychiatry, having obtained her FC Psych from the College of Medicine of South Africa in the same year. Dr. Baker has been practicing full-time in private mental health care since 2021 and currently serves as at Evexia Psychiatric Day Hospital in Midstream, where she works as part of the multidisciplinary team. She has special interest in diagnosis and treatment of mood disorders, anxiety-related disorders, trauma-related disorders, and substance use disorders. Her research has been published internationally, include a qualitative study on the challenge faced by mental health care users in primary care setting, the community mental health journey. Dr. Nadia Baker, thank you and welcome, and thank you for gracing us for these presentations. We're looking forward.
Thank you so much for the introduction. I was asked a few weeks ago to come and talk to the physicians and the emergency department. And I said, all right. It seemed like it was going to be a very low-key discussion, but it seems over the past 2 days, this has now evolved into a situation where there's been posts on social media and there's been Teams meeting links going around. So, Cornell, thank you for the heads up. I appreciate it. Initially, I was wondering what to come and talk to you about, but then there was a request to talk about the management of the aggressive patient in the emergency department. And I thought to myself, geez, it's really been a while since I've set foot in an emergency department. And I was not sure about what the latest research said or what the latest procedures were. So after doing a literature review, I realized that actually not much has really changed. So for me, this is more of a brush up, of knowledge that I already had. But I do hope that this will be an informative session for all of us. It's always a privilege to learn alongside each other. Right. This was an article that was published in the Medical Brief just last week, and I thought I wanted to share it with you. One, because it is quite applicable to what we are talking about this morning. And two, violence and aggression in the healthcare setting is a big problem right now. I'm sure some of you, if not most of you, have experienced an aggressive or an agitated patient in your practice. I know I sure have, and I think I've had my fair share both in the public sector as well as in the private sector, believe it or not. And it's always a very frightening experience, especially if someone gets injured. So I hope by doing this talk today that we will feel a bit more empowered and ready to handle situations if they do arise. So acute behavioral disturbances are associated with psychiatric illnesses, physical illnesses, substance abuse, and personality disorders. According to a NICE expert committee report, they found that the lifetime prevalence of violence in the non-psychiatric population was about 7.3%. But the moment that we talk about the psychiatric population, that shoots up to 16.1%. In patients with substance abuse, the lifetime prevalence of violence is about 35%. And if we have comorbid mental illness and substance abuse, that suddenly goes up to 43.6%. So the crux of the matter is that our emergency departments and psychiatric units experience far more aggression and violence than any other healthcare setting. So the point is, violence in the healthcare setting is a big problem. On the international front, it seems that about 50% of healthcare workers have fallen victim to violence at some point in time in their lives, and this goes up to 79% for those who work in the emergency department. Also seems like violence has worsened during the COVID-19 pandemic. According to an interrupted time series analysis performed in Italy between 2017 and 2021, they found that there were about 4.3 violent attacks per 100,000 encounters per month, compared to pre-COVID or pre-pandemic statistics of 0.04 violent attacks per 100,000 encounters per month. In the South African context, about 2/3 of South African healthcare workers have experienced some form of violence at some point in time during their careers. It seems like female staff, and in particular nursing staff, are more commonly affected, and verbal assault seems to be the most predominant form of aggressive behavior. Effective management is obviously paramount to reducing the risk of serious injuries, both to patient and to the clinical team. But in the South African context, we do face a couple of challenges. Some of these include emergency department architectural design and layout, high patient to nursing staff ratios, lack of trained staff, lack of security personnel, which seems to have been the problem in the article that I quoted earlier, high crime and substance abuse rates, as well as limited medication options, probably more so in the public sector than in the private sector. So agitation is characterized by the excessive motor activity with increased excitability and a deterioration in normal functioning, and this may eventually lead to violence or violent outbreaks. It should be regarded as a medical and a psychiatric emergency. And as they say, prevention is probably better than cure. So if we are able to identify these patients or potential problems early on, we can intervene quicker and prevent things from escalating. So some of the signs to be on the lookout for would include patients making threats, even those patients who threaten to leave the emergency department, any provocative behavior, angry demeanor, demanding patients, patients are who are very loud and aggressive or even mumble, those who are very restless and pacing up and down, those with tense posturing such as clenching their fists or grabbing onto rails, and displaying any other forms of aggressive behavior such as hitting walls, banging doors, or even throwing objects. It is very important to identify these patients early on and to prioritize and expedite their interview and intervention in order to prevent things from escalating. When we talk about safety measures and preparation for in case these things happen, in the literature there was quite a lot of articles recommending that emergency departments should be equipped with metal detectors. Alternatively, I think it is safe to assume that all patients may be armed until proven otherwise. And every emergency department should be equipped with a private but not isolated interview room with doors that swing outwards or towards the outside of the room. Hopefully, if possible, have 2 exits available. All potentially dangerous or heavy objects should be removed from the room, and security should be close by in order for them to intervene if necessary. For us as clinicians, it's always important to also pay attention to what we are wearing. So be wary of ties, bow ties, perhaps even jewelry around our neck, including our stethoscopes. I reckon this is why psychiatrists don't wear stethoscopes around their neck, or why they even bother to have them. So it's also important to make sure that we position ourselves in relation to our patients appropriately. So be outside of an arm's reach, make sure that you're always patient-facing and never turn your back on a patient, and always make sure that you are positioned between the patient and the door, that if you need to exit quickly, that you can do so. I think it's also important that as a team in the emergency department, that we are all on board and that we are well aware of perhaps procedures or standard operating procedures that might be in place. It's important that we all know what protocol to follow once things start escalating, and what the way would be to rapidly notify either a colleague or security staff if situation in the emergency department does escalate and a patient becomes aggressive. This is a non-exhaustive list of potential medical causes for agitation or aggression in patients. Very high up on the list, toxicology. I think we've all had to deal with those intoxicated patients, or even those who are intoxicated with stimulants, but don't neglect withdrawal. Alcohol withdrawal and sedative withdrawal patients can also present quite aggressive. Then metabolic disorders, hypoglycemia and hypoxia up there on the list. Neurological conditions, those presenting with strokes, intracranial lesions, or central nervous system infections or seizures. Other medical conditions, hypothyroidism and shock. And then the common psychiatric conditions, psychotic disorders, personality disorders, mania, intellectual disability, and autism spectrum disorders. So the first course of action, if a patient does become aggressive in the emergency department, is to start intervening with verbal de-escalation techniques. During such an intervention, one needs to be mindful and respect personal space. Focus on avoiding provocation and not to provoke the situation any further than it already has been. Establish verbal contact. Use simple, clear, and concise language. It's also important to try and identify feelings and desires by asking questions to a patient, for instance, like what are you hoping for, or asking direct questions such as, do you want to hurt yourself, or do you want to hurt anyone around you? It's important to listen very closely and attentively and to reflect back on that. By instance, saying something like, tell me if I hear you correctly, because that can foster a sense of trust and feeling heard by the patient. It's also okay to agree or to agree to disagree. And this can manifest in saying something like, there are other people who would feel the same way that you are feeling. Again, that might make the patient feel like they can trust you, and that can help in de-escalating the situation. However, it's also important to lay down the law and to set down boundaries. And this can be by saying something like, I can help you with X, but I cannot allow you to do Y. After such an intervention, it's always important to afterwards go and debrief with the patient, go and talk to them again after the situation has calmed down in order to restore the therapeutic relationship. I think it's also important to take note that during such a verbal de-escalation, this can also be an opportunity to start offering a patient oral calming medication if they are willing to engage in that. Once verbal techniques or methods have failed, unfortunately, physical restraint and parenteral medication might become necessary. It's important to note that the aim of medication, contrary to popular belief, is not to make the patient sleep and not to make them sedated. It really is to calm them down. The aim is to really get to calm a patient down within a 2-hour window period, whilst also doing so by and avoiding rather any adverse events or effects. It's important to note that administering calming medication does not address the cause for the agitation. The hard work still remains in finding the cause for the agitation and then dealing or treating that as soon as it's been identified. Fortunately, we do have a couple of options, including our antipsychotics, both first generation and second generation antipsychotics, our benzodiazepines, which I'm sure most of us are quite familiar with. And then as an absolute last resort, we can resort to ketamine or dexmedetomidine. In terms of our first generation antipsychotics, probably the most well-known one in the group is haloperidol. Our antipsychotics work on inhibiting dopamine, which tends to help alleviate psychotic symptoms and then the agitation that's been associated with that psychosis. Also important to know that structurally, some of our antipsychotics are quite similar to GABA, which is our major inhibitory neurotransmitter. So it can also interact with GABA receptors at high dosages. Benefits of haloperidol includes that it has a very long track record of being safe and effective in the acute setting. It does have minimal non-psychiatric medication drug interactions, and it seems to have little impact on vital signs, especially at lower dosages. The moment that we go over 10 milligrams and we start using intravenously, we do run the risk of causing hypertension, prolonged QT intervals, and disorder. So I think those are things to be on the lookout for, as well as, of course, our extrapyramidal side effects, it being haloperidol being a first-generation antipsychotic. The risk of extrapyramidal side effects is about 20% with haloperidol and our first-generation antipsychotics. Seems to go a little lower to about 6% if it is used in combination with lorazepam. In order to counteract extrapyramidal side effects, it's always wise to just have some piperidine at hand for in case this happens. I've had to use it a few times during my training, and it's quite effective and it helps quite quickly. Other extrapyramidal side effects besides acute dystonia that patients might experience include catatonia, and then we're also on the lookout for neuroleptic malignant syndrome, which might develop. So for haloperidol, we're looking at about 5 to 10 milligrams, either orally, intramuscularly, or intravenously. Intramuscularly and intravenously, it seems to start working within 30 minutes. Remember that the maximum dose is about 20 milligrams per 24 hours. Orally, we can push a little bit higher to about 30 milligrams. We also have the dopridol available for intramuscular and intravenous. It does seem to have a rapid onset of action within 10 minutes. which is also an alternative, even though I do believe that haloperidol is most freely available. And important to note that even though first generation antipsychotics are often preferred after our second generation antipsychotics, first generation antipsychotics are still preferred for those with alcohol intoxication. When we talk about our second generation antipsychotics, we have a couple in this group. We have olanzapine, risperidone, and ziprasidone. I think the benefit to these are that the risk of extrapyramidal side effects are quite less, about 1%, but we still run the risk of causing prolonged QT intervals. I think it's also still a very good option for patients who present with agitation secondaries to psychosis, because again, as an antipsychotic, it's going to address the dopamine drive that we have, and it can actually help in addressing the psychotic agitation a little bit better. Funny enough, there's not a lot of research, or the literature does not say much about the combination of second generation antipsychotics with benzodiazepines. There's quite a lot of research that proves that, for instance, haloperidol plus lorazepam is quite effective and fairly safe to use in combination, but not so much with our second generation antipsychotics. And I think it's particularly important to pay attention to the fact that the parenteral use of olanzapine with benzodiazepines are not highly recommended because of the risk of respiratory depression. Options that we have, as I said, is olanzapine. Olanzapine can be administered about 5 to 10 milligrams orally, intramuscularly, or intravenously. Intramuscular onset of action is within about 15 minutes, intravenous within about 5 to 10 minutes, and we sit with a maximum dose of about 30 milligrams that we can be administering within a 24-hour period. I think always just be wary of the risks if a benzodiazepine was to be used in combination with our second generation antipsychotics. Alternatively, we also have ziprasidone, probably a little bit less effective because it's only a partial dopamine 2 antagonist, but nonetheless, it's still available in intramuscular formulation, about 10 to 20 milligrams, onset of action in about 15 to 20 minutes. Alternatively, we also have risperidone. It is available in an oral dispersible tablet, also quite useful for some patients, and we usually recommend about 1 to 2 milligrams to be administered. However, the onset of action can take up to an hour. Just want a note, just one on the antipsychotics. I don't know how many are familiar with Accuphase. It's a first generation antipsychotic. It is not ideal for the emergency department because it does not cause rapid tranquilization. It is something that should only be used in specialist psychiatric departments because it does cause sedation for up to 3 days. So I think just be wary that it's something that is available, but it's not adequate or appropriate for the emergency department. When we get to our benzodiazepines, I think this is the one that most people are fairly familiar with. We have a couple of options here: lorazepam, midazolam, diazepam, and clonazepam. They seem to be effective, especially for those patients who present with stimulant intoxication or alcohol withdrawal. You really need to be very wary for the patients who present with alcohol intoxication, because adding a benzodiazepine might cause respiratory depression, which we need to be on the lookout for. Benzodiazepines work by acting on GABA receptors. Again, as I mentioned earlier, GABA is our major inhibitory neurotransmitter, so it helps in alleviating agitation through that route. Lorazepam, I think, is very often used in the emergency department. Orally, one can look at 1 to 2 milligrams, or intramuscular, intravenously about 2 milligrams. Onset of action is fairly rapid, and its effect lasts for about 6 to 8 hours. Midazolam also seems to have quite a rapid onset of action, but the duration is said to be up to 2 hours, so it is a little bit shorter acting. And then just a note on diazepam, as I hope that you are aware, it's definitely not something that we want to administer intramuscularly because its absorption is very erratic and unpredictable. So if we're going to use it, we do want to use it orally or intravenously. Clonazepam could also be another option to be used, about 0.5 to 2 milligrams orally, and in some cases it can also be used intravenously. So, as I mentioned earlier, as a last resort, ketamine and dexmedetomidine might be options, but these are really reserved for patients who've had multiple doses of antipsychotics and benzodiazepines and who still remain agitated and fighting their restraints if they are restrained. Ketamine can be administered either intravenously or intramuscularly, and dexmedetomidine is administered as an intravenous infusion. Please be aware that if this is the route that one takes, that patients need to be monitored extra carefully afterwards with continuous ECG, pulse oximetry, and capnography. They need to be closely monitored to prevent any adverse events or reactions. So now that we've run through the list of what is available, I thought that I wanted to summarize just what we would be using in which context. So when we look at mild to moderate agitation for the patients who are intoxicated, especially those who are intoxicated with recreational drugs, our option or our medication of choice is are the benzodiazepines. For those who are intoxicated with amphetamines and who display psychotic features, it would be wise in psychotic patients to consider second-generation antipsychotics. And then in those who are agitated, whose agitation is related to alcohol intoxication, again, we need to be very sparing with our medication, and our first course of action would probably be, and the safest course of action would rather be to opt for an antipsychotic. Haloperidol, again, has a very long track record of being quite effective and safe to use in these patients, but as an alternative, we have droperidol that can also be administered intramuscularly. For patients who present with agitation due to psychosis, as I've mentioned earlier, our second-generation antipsychotics are definitely the preferred choice. If patient allows, one can opt for oral medication, and if they are cooperative, and offering them 1 to 2 milligrams of risperidone can be useful. But for patients who are not willing to cooperate and take oral medication, we're looking at parenteral options such as olanzapine, ziprasidone, or haloperidol. Again, be wary if the need arises to administer benzodiazepines, perhaps at a later stage. We need to be wary of that respiratory depression, and it is recommended that if we're going to use olanzapine with a parenteral benzodiazepine, that we at least allow an hour between the dosages. If after an hour a patient or the patient has not calmed down and the agitation still prevails, it might be wise to repeat whatever was given the first time around after an hour, or the addition of lorazepam can be considered. For those patients who present with delirium, as you hopefully know, delirium is recognized as an acute confusional state characterized by the decreased level of consciousness with a change in or disturbance in awareness, particularly cognition and attention, that develops very acutely and tends to have a fluctuating course of action. Important that even if we're going to administer calming medication, that this is not the answer or the solution to the problem. The underlying medical cause still needs to be identified and corrected. However, if patient is very agitated and we suspect that it might be due to alcohol or benzodiazepine withdrawal, administering a benzodiazepine would be appropriate. If we suspect that the delirium might be to another cause, oral or parenteral antipsychotics may be considered. Again, be wary. If we do opt for benzodiazepines, there is a chance that it might worsen or exacerbate the delirium in some cases. In those cases where we are not sure why a patient is agitated, or if it seems to be that the cause is quite complicated, this is a simple rule of thumb that could help in the short term. If the patient does not present with psychosis, we can go for benzodiazepines. If they present with psychosis, opt for an antipsychotic. In severe cases, a combination of haloperidol plus lorazepam can be useful. This has been, again, well studied, and we fairly know what to expect when we do administer this. Patients who are severely agitated, and we need to calm them down quickly in order to prevent any risk of harm or danger, a combination of haloperidol and lorazepam is appropriate. And in extreme cases, this may be repeated even after 15 minutes. However, bear in mind for patients who have received multiple parenteral doses of antipsychotic, ECG monitoring becomes very important to pick up on those prolonged QT intervals. Alternatively, if this has failed, we're looking at ketamine and dexmedetomidine. So congratulations, you've now successfully sedated or calmed your patient down, but this is really where the hard work now starts, because that patient cannot be left alone. If a patient is medically sedated, there needs to be quite stringent or very strict safety protocols in place to monitor these patients. Every emergency department should be equipped with an up-to-date and frequently reviewed standard operating procedure to manage aggressive patients and to monitor them after they've been potentially restrained or sedated. Personnel in the emergency department should familiarize themselves and should undergo appropriate training to manage such patients. The reality is that the risk of serious adverse events is really low if sedation has been administered appropriately and appropriate monitoring takes place afterwards. We should consider continuous pulse oximetry for those patients who are over the age of 65, those who became overly sedated, those who are intoxicated with alcohol, also those who have been restrained and those who have received multiple parenteral dosages of sedatives. ECG monitoring should be in place for those patients who have, like I said, also received multiple parenteral dosages of antipsychotics. And if you have patients who've received infusions of ketamine or dexmedetomidine, continuous cardiac monitoring, pulse oximetry, and capnography becomes important. If a patient had to be restrained, or if it was necessary to restrain a patient, this is also something that needs to be monitored very carefully. The Department of Health has actually issued a 16-page document called the Policy Guidelines on Seclusion and Restraint of the Mental Health Care User, which is worthwhile checking out. It is available on the internet. It's not a heavy read, it's just about 16 pages, but it does give a fair overview of what should be happening and how a patient who is restrained or secluded should be monitored. Important to note that if a patient is restrained, it should be prescribed. It has to be prescribed, have to prescribe very specifically how a patient is restrained, for how long they should be restrained, and how they should be monitored. You will be in great trouble if that has not been recorded. There's also a mental health care form 48, which is really restraint registered, that should be completed if a patient is restrained, and this must be sent to the mental health care review board for review after the meeting. If a patient is restrained, it's important that they at least be monitored every 30 minutes. Personally, I would recommend it that a patient be subjected to observations every 15 minutes. But according to the Department of Health, they recommend at least every 30 minutes. And during such observations, very particular notes pertaining to the patient's behavioral response, their vitals, their hydration status and toileting should be recorded in the clinical notes. Important to note that as time passes and as a patient becomes more cooperative and less agitated, that we should consider lessening the restraints. If a patient is restrained in a prone position, or if they continue to fight their restraints for more than 5 minutes, it does become important to also have continuous cardiac monitoring on them. Adverse reactions that we should be on the lookout for include rhabdomyolysis, hypothermia, metabolic acidosis, and cardiac arrest. Patients who are restrained should be repositioned at least every 2 hours, and during such a break, the basic needs should be met in terms of hydration, nutrition, going to the bathroom. And if restraints are reapplied, circulation checks should be done to make sure that they are safe. Just a brief word on agitated patients, or the elderly or demented patients who present with agitation in the emergency department. There's actually very little research on this population group in terms of sedation, because very often they are excluded from clinical trials. But a good rule of thumb is that if sedation is going to be administered, that we go for half the usual adult dose. We do try and avoid benzodiazepines for a variety of reasons, one being that very often they can have a paradoxical response. So instead of them calming down, they might become more agitated or even confused if we do administer benzodiazepines. And benzodiazepines have also been associated with increased confusion, falls, and the risk of femur fractures in this population. So we try and avoid it if at all possible. Also for those who are struggling with dementia, particularly our Lewy body dementia and Parkinson's dementia, we need to be very careful with our antipsychotics in patients with Lewy body dementia because they tend to be neuroleptic sensitive. So I would personally not go for something like risperidone or even olanzapine. If anything, I would consider a very low dose of quetiapine actually in these patients. For those who suffer from Parkinson's dementia, we want to be wary of our first generation antipsychotics because they can worsen Parkinsonism. And to conclude, when it comes to the agitated or the aggressive patient, medication should never be the primary form of restraint. We want to prioritize non-pharmacological interventions such as verbal de-escalation techniques, or even just to simply remove a patient into a more quiet or a less stimulating space and assisting them in calming down in such a way. Medication, if being used, it should not be aimed at sedating or making a patient sleep. Really should be aimed at calming them down in order for us to investigate and to intervene and to buy us some time. Always, and when we do opt to provide or prescribe medication for these patients, we need to consider the underlying cause of the agitation, and subsequent to calming down, we need to make sure that we do a thorough investigation, identify the reason for the agitation, and then intervene appropriately afterwards. Thank you so much for listening.
Thank you so much, Nadia. This was quite a very good, insightful presentations. And I think today I feel confident to manage aggressive patient. I need to the guy there on whether you have questions, but I'll start with the first question. I mean, what do you think should be our first choice for patients that are in clinical care, especially medical ICU, that got a lot of multiple medical problems that present with the agitation, aggression, and most of those patients have got hyperactive delirium. How do you actually approach them? What would be the first choice? Because we know that haloperidol is not available in South Africa, I think, for quite a few weeks. I don't know whether now it's available, I'm not so sure. What are the choices that we can use?
I think obviously first and foremost to know what the cause of the delirium is. I think we've covered that, and that's the first point of entry. In patients like that, depending on what the cause of the delirium is, I reckon something like a low dose, but really low dose of benzodiazepine, something that's fairly short, short acting, something that we have more control over. And I particularly like lorazepam. I think it's quite effective. And we have options from sublingual administration to oral to intravenous and intramuscular. So I think for most people, we actually feel quite comfortable with that. But again, to keep it as low as possible at a minimum, and then to be wary of the elderly because they are more prone to delirium. So if we use sedation, we need to be mindful of the potential side effects. So even in those patients, like I've mentioned, perhaps a very low dose of quetiapine, depending on what else they're on, might be useful.
Anybody out there before we go open the floor inside here? Let's see who's the guys out there. Morning, guys. Anybody with question?
This break, you normally ask.
Okay, guys, anybody with question inside? Come now.
Can I ask something?
Yes.
So the way that it's been happening currently, to be truthful, is patients get geodin and
Yes.
then a couple of hours later they get geodin again.
Yes.
How long should you wait between, if you choose that drug, if that is your chosen drug, how long should you wait before you do that again? And what are the side effects that you should actually be looking out for? Because we've had a patient with malignant hypothermia that was sort of missed.
It's quite detrimental if that happens.
Yes, it is.
So just on a personal note, I think geodin wouldn't be my first choice. As I said, it is only a partial dopamine 2 antagonist. So it seems to be less sedating if that is what you need at that point in time. So it wouldn't necessarily be my first choice, but I know it is available, and I think that's what's happening out there. I think if you're going to repeat intraparenteral antipsychotics, we should look at perhaps an hour, depending on how agitated the patient is. Some guidelines have said that, for instance, haloperidol and lorazepam you can repeat as shortly as 15 minutes after if you're not getting the effect and it's becoming a difficult situation. But usually we allow at least an hour, according to most guidelines that I've seen. Side effects that we need to be on the lookout for, cardiac side effects. Okay. Cardiac side effects, again, the QT prolongation. It's not going to make a patient very sedated, but it might also contribute to hypotension, which again, if you're sitting with a patient in the emergency department, is perhaps in shock or is already dehydrated, you want to be careful of that hypertension and inducing that any further. So again, close monitoring, especially for those patients who've received parenteral sedatives, being it the antipsychotics or other sedatives. And the moment that they start getting a second dose, you need to make sure that you cardiac monitor them quite closely.
And I also think if the patient is a known psych patient and now they came in, for example, with an overdose of some kind that you're not sure what they actually took, and now you're giving something on top of that. So those patients, even not just in the emergency department, they need like extra careful monitoring in ICU. That's a patient you have to put your brightest nurse there, and they know what to actually look for when they deteriorate.
I think that's where standard operating procedures and proper training becomes very important. Not everyone is trained. We don't have a lot of psychiatric now. I don't think anyone is trained in psychiatry in this hospital. So we don't necessarily have staff that's on top of it that knows exactly what to be on the lookout for. So it does become problematic. But yeah, especially if they've been intoxicated or they've taken an overdose and they become agitated, we need to be on them very closely and very carefully because the adverse events can be quite severe. And if we miss them, legally we're going to be in trouble.
So I've seen, it's usually with withdrawal symptoms and Purata. All the old people are on Purata. And then you find out eventually they're on 15 milligrams. As you say, you must look for underlying causes.
Yes.
Try and find, first of all, you have to get the patient a bit calm, but you have to look for an underlying cause. And the other thing is nicotine and alcohol is actually quite common in our ICUs and stuff.
Yes.
And then also the day-night, people get confused because there's no stop. There's always monitoring. They're always taking bloods. The lights are always on. So it does confuse
it definitely
patients.
does confuse and contribute to the confusion. So we try and orientate patients if it's at all possible for a patient to go and spend some time outside, which in some cases it's not possible. But I think that's also when nursing staff becomes important, to try and, if it's dark, try and keep the rooms dark and quiet. If it is light, keep it bright, and try and orientate patients.
I think the message of it is that not every patient in critical care needed sedation require aggressive management. I think look for underlying cause. Electrolytes is very important, especially for sodium, and then hypokalemia, and you require also the culprit and also the magnesium levels. So sometimes correcting them and also, restraining patients provides much better if they don't hurt themselves. And I always remember a lecture by Prof. Richard was always saying he liked his patient to be very active. So the more they have active, that's not mean that you must sedate them. And sometimes what you need to do is just to talk to your patients, and and sometimes they actually do make sense, Yeah.
Sorry, Tony. Just one more question. So we live in the middle of geriatricville. So a lot of our patients are slightly demented, and the moment they get into ICU, it's just it's chaos.
Yeah.
So what I was wondering is there something that we can do to sort of prevent that? Because they're either going to get a hypoactive delirium or a hyperactive. It's almost a given. Is there something that we can sort of give them at night to try and sedate them, like a low dose of dopamine or risperidone, to just for the time that they're there, to just sort of help us help them, help us
I know, like I've previously come across an article that actually recommended even just giving some circadian and some melatonin to try and regulate those day-night cycles. That can be quite helpful, especially, you know, in the ICU setting where, again, we don't know if it's day or night, you don't know if you're coming or going. So try and keep that consistent. That can be quite helpful. But if it's becoming difficult and this patient is really not sleeping at night and it's just becoming chaotic, I have opted for even something like a low dose of trazodone. Okay, that can be useful at night, 50 milligrams, and some patients are effective, or really low dose of dopacol, like 12.5 or 25 milligrams. That's hopefully not going to cause too many drug interactions and sedation.
That's sort of what we've been trying to do, not to over.
I think we mostly have used, I think our guideline in ICU, especially for elderly people, I think we have used always Seroquel or Dopacol. I think 25 milligram, that's the max that we go. And we have always tried to stay away from the other, it's like Risperdal. I find it very, that they tend to have what we call cumulative effect. You give them Risperdal after time, then they go into deep sedation completely for a long time.
Yes.
And that's the issue. Our pharmacists, do you want to give us comment about haloperidol? Do we still have it in the country? Do we have it in a pharmacy?
The injections has been discontinued. So there is generic tablets. So the original product has been discontinued in the country. The oral formulation, there is generics listed, but we'll have to check with the ethical body regarding availability. But at this point, there's no haloperidol in the pharmacy.
So if you need it, we need to have section 21.
I'll first have to check.
Okay.
I think what, firstly, well, I think it was an excellent lecture, so recapping everything. Our emergency departments is just not designed to deal with psychiatric patients at all. When I worked in Canada, every emergency department had a padded room. And there they can't bring padded room. South Africa, it's a glass room. So luckily, I mean, certainly in the area that we work, fortunately, we don't have as much as certain other areas. But like you say, the dangerous equipment. Sometimes we're forced to put the patient in a room with the most things to throw around. So that's certainly a problem. I think the designers by emergency department haven't taken that into consideration. Then I, for the most of my career, I've used haloperidol, and I mean, all those you only had Valium, but now we've got lorazepam when it's available. I find that, you know, you mentioned 5 and 2, but so for me, the problem is, especially if you give it IMI, you give 5 and 2, then you sit in your wait and nothing happens. And you have to keep that patient restrained for over half an hour. So I must be honest, in practice, IM doses, usually we had to give lorazepam 4 milligrams, not, I think 2 IM is probably not going to do much.
I think if you have someone that can monitor the patient, because we're always just wary of over-sedating patients, especially if you're not sure, you know, what they've taken and, you know, what the underlying cause might be. So if that's what you need, then obviously first point is do no harm, and we're trying to prevent anyone from getting injured or hurt, including the patient. So if that is what you need to do, then, you know, that's what you need to do, but to make sure that there's adequate monitoring if you've decided to do that. And that can be lacking in some instances.
So if you've got enough staff, now principle for one person per each limb, one for the head, and then the doctor or assistant puts up the IV line and gives the injection. Now that's a nice thing of how haloperidol. He was able to give 5 milligrams of IV iron as a whatever value, whatever you had at that time. But now Judon, you cannot give IVI.
No.
So now we force you give Ativan 4 milligrams, Judon 20, and now you sit in your wait. And sometimes it's it depends on the cause. You can sit there for a very long time. And that's a danger with intramuscular medication in an acutely agitated patient. Now you wait. At what stage do you now give something more? Because it's labor intensive. You've got a busy emergency department. Now you've got 5 people restraining this person. Everybody nowadays frowns upon emergency department physical restraints. I can't remember when last we used that.
But I think it's very important that when you give IM medication, you need to know that I think you need to palpate the muscles properly, that you're actually giving the muscles. Because if you give the potential space between the fascia, the medication is not going to be absorbed very quickly. That's, I think, is very important because sometimes people get panicking and they quickly just they put that, and that's very wrong. So I think you need to, as the technique must be right. It's very important. And second thing, obviously, I think she also mentioned with the Juden. Juden, sometimes it depends on the patients and also depends what chronic medication the patient has been on. You know, obviously the patient been on a lot of previously like benzos, a lot of other medication, means somehow they don't, their tolerance is, you know, is very high. So that means they don't respond super quickly. So you can't have to be patient with them. And I think maybe you consider restraint, or sometimes I say most of these patients, sometimes talking to them, sometimes actually can calm them down, allow medication to wean itself off. And sometimes when they calm down, then they actually become very sedative. But if there's this kind of aggressive between the patients and the healthcare professional, if, you know, and obviously the noise around it, the unit need to be very quiet. Because again, if there's so much noise that they feel like they've been attacked or something like that. So I think we just need to be very technical how we actually go with them. But I think have Judon is very important. In ICU, we have always given 10 and then see what happens. If after a few 45 minutes, they're nothing, then you can give the other for 10, you know, because you don't want to give 20 patient knockout, then they go into cardiac arrest, which is again, you know, that becoming medical legal issues.
The other thing, of course, is security. So, in my experience, first people run away is the security. And I had an agitated patient in Pretoria that the police brought in. The guy was 6 foot and the police were like this size. And the first people that were beaten up by was the two policemen, and then it was me and him. And, you know, so it becomes a challenge. The one thing with alcohol, we always thought that there's alcohol, like a delirium. You have to be very careful of antipsychotics for haloperidol, for instance, because it lowers the threshold for seizures. So you kind of lean more towards benzodiazepines, even if they do have delirium. You have to be very careful. I'm not sure. And now if you don't know that.
Yeah, I think what it still seems it's now unfortunate that haloperidol now have an upset.
So there is a Section 21 IV haloperidol. However, SAPRA is currently rejecting all of the other Mediconics applications because they want discontinuation letters from 4 different South African registered manufacturers, but they don't even make an IV for like an IV formulation. So I'll try, but so there is a Section 21 product. I'll try and apply, and then I will let everyone know if I managed to get approved.
That's our lovely pharmacist. She's back.
But you often find South Africa the medication that used to be the most effective are also the ones that get discontinued first.
Whatever reason, why? Because
They don't make enough money.
It's too cheap.
Yeah.
It is just too,
Yeah.
it's like penicillin. It's just too cheap.
I think I would suggest if you can, let's try to see whether they can bring haloperidol back again, and then we can motivate for it. And also emergency.
Because it's still on international guidelines. I mean, it's still
So
recommended.
you do the second base, basically. It's not
Not
awful.
a good thing. It's really not that great.
That's what we have. Now, the other
Has
question
limited
is,
use
you
of
mentioned
psych-
ketamine. Now, ketamine has got, can cause psychosis in itself.
It causes major
Yeah, I mean,
hallucinations.
it's difficult. I mean, we're having ketamine clinics popping up on every street corner right now, and our SASOP had to like make a statement the other day. It's lowish dosages, I think, and again, we're not trying to, you know, sedate a patient. We're trying to just calm them down, and it can help. But again, this is like really last resort if you've gone, you know, like and really tried everything else. It's not ideal, but in terms of options, this is what we have available.
Is Zyprexa not an alternative to the Geodon? Not really.
Well, that's olanzapine.
Yeah.
And especially if it is part of what we can use. But again, if we're going to use that with benzodiazepines, it becomes a little bit difficult because there is research that has proven that it does, you know, cause respiratory depression. So we need to be wary.
It's longer working.
Yes.
So that's the problem. So if
Yeah,
you
exactly.
have extrapyramidal side effects, you're going to sit with that patient overnight. holding their hands while they're spasming. So just be aware of that.
I think the best solution I always say when you're using anything to sedate patient, make sure it's reversible. Yeah, and that's why I think the benzos probably are much more superior because you could reverse everything else. If you can reverse, unfortunately, you might end intubating patient, or the patient might actually demise. So you have to be very careful with that. And also, I think probably with the haloperidol, you could counter the extrapyramidal side effects. So I think you always have to balance where your benefit side.
Christian, clotyping, is that still available?
It is. It's very, very old. I actually still have patients from psychiatrists who's been in the industry for much longer than I am that still come in and they're on etamine, right?
But that injections work really well.
No, funny enough, it's not really. I know about it. I've seen it. I've had to use it while I was doing, like I was still in the public sector because that's where we still had it available. But it doesn't seem to appear on any guidelines. Besides South Africa, I think it's available in Luxembourg and Belgium, but not many countries actually have it available. But
Because that was a good combination of antipsychotic and sedation.
It's just the hypertension. You need to monitor the patients for hypertension if you're going
Especially
to
with
use that.
IV, yes.
Yeah.
It's still available.
Outside there, anybody for question?
I think we do have it. Just double check. It expired recently on the shelf, so I'll just have to check if we actually bought it.
Don't be nervous.
And I have one more comment, sorry. So I think it's very well to treat it, but again, just if the patient comes in, just really think about what is causing this. Is this a meningitis? Like
Yes.
even forbid like a pneumococcal meningitis. That's the only time I've had an aggressive patient before. The rest of the meningitis, the patient's just sort of sick. But that's the one thing. And then just make sure. I think in this area that we live, if it's a younger patient, please do a drug screen. Please check the alcohol levels for medical legal purposes. And then the other question is this primary psychiatric, and should we stabilize and send somewhere else?
I think also just to add to your point, I think we must also remember that the aggressive behavior is, for me, it's kind of the origin normally is the CNS, central nervous system. And I think most of these patients deserve a scan. So make sure that, you have a patient ICU that actually become delirious, but then after a scan, which was done by Liesel, and she got a frontal kind of stroke. So the point is that I think we are very lucky in Midstream Clinic that the fact that we have a psychiatrist too, we have also neurologists, we have physicians, we have very good, amazing casualty officers, and I think probably not short of expertise. So make sure that you involve them and somehow get opinion. It costs you nothing, so the patient get the best treatment as possible. And also, we also got rheumatologists. Sometimes lupus can also present as such. So most of the time, PHP patients that present with this kind of behavior, there's underlying problems. You always must ask yourself, this patient being well at home, what have changed up to this point? Whether they're demented or not, something might have to push them to what is currently becoming a problem. So step backward. If you said again, and look at that problem, just don't rubbish them up in respect of their age or whatever it is, because the patient belongs to somebody at home, it means something to somebody. So you as a clinician, make sure that you actually go a long way and try to find the underlying problem for the patient. And I think that's very important. Even vasculitis is one of the causes of the aggressive behavior. So there's multiple causes. And I think we need to do it. And also Engelbrecht say withdrawal is another problem. Again, most elderly people on antipsychotic, the reason because they lose their spouse or they're having family issues. So they've been on long antipsychotic treatment or benzos. And most of these patients, sometimes when they come to hospital, they got delirium and they don't know what medication they're on. So you don't have those informations. And somehow you have to find a way to make sure that those people, you need to find a proper history and also maybe try to contact the family as quick as possible and try to see if they can get those information.
Well, I think that for most patients that where there's potential drug usage, alcohol usage, without the underlying psychiatric condition, I think for us in this department it's important to what we say, rapidly and adequately sedate them, do a proper, effective metabolic and toxicology workup. They must all get a scan, right? And then admit them to ICU. Keep them as sedated as required in the control environment until the next day. And I find that most often these patients wake up the next day, like, well, where am I? Why am I here? And then the crisis has been averted, and then it can be further investigated. I find that if you try to keep them in easy and then try to for them to wake up, that's just going to be a
It's not
disaster.
ideal. I mean, it's an emergency department. I'll be babysitting patients in there, and it's very busy. I think that's also not ideal for patients who are
So
very
they don't get upset like
Right.
they should. Yeah.
All right, we're left with 5 minutes. Let's get two final comments. And I think probably Liesl, you're the neurologist. Anything
Make many
noble? Any noble for the audience out there? I mean, special case officers, because they're going to be calling you for the scans. So that at least, what's your opinion about that? Are you happy with
Look,
that?
I will always cover you for a scan. I will write a motivation if you need a motivation. I think it's more important for me to rule out something structural. You won't get me pushing against that. The other thing that I was just thinking about that we're seeing more and more is autoimmune encephalitis. So those patients can also come up very strange, acting extremely strange. So always just have that in the back of your mind. A patient with no previous psychiatric history that just comes in with sometimes a movement disorder, sometimes with just strange behavior. Their tox screen is negative. Those are the kind of patients that you find me for ASAP. So just think about that. I'll still give you a presentation about that, but it's something that's coming up more and more, and it's missed.
Thank you.
Well, let's
Bianca?
do the patient that presents with the first episode of psychosis in a skin. I mean, that was always a red flag.
Yeah.
They need to be properly.
And they deserve a proper workup.
Bianca, any comment?
No comments.
Nadia, can you give us your final words? It's been great.
I think I've said enough, but thank you for the opportunity. I think this was a wonderful platform to just talk and learn from each other. Appreciate it.
I think today I learned enough. I'm really a lot, and I'm looking forward to be learning more. Our podcast will be available next week. If you missed the lecture, you should be able to access it by the link when we post the next topics. And thank you guys. We appreciate it. And I think, this project was started as a small, between ourselves, myself, Cornell, and Dr. Godinho, who is currently just on leave. But we really wanted to make sure that it's learning, because you cannot practice. Private practice is not about money as people thought. There's an opportunity to learn, because we're seeing a really patient who are more sicker than the state patients, because in the past, we are told that patients stayed more sicker, but it's not true. In private, you see really very, very sick patient, and I think we need to have ongoing learning, and hence there's this platform, and I just hope that we continue to present a credible, like our speaker has done, and we'll try to learn from each other each and every day. We're not perfect, but hopefully that one day we'll reach there. Thank you.
Don't say 8 to 9.